podiatry the last 2 years, and I believe everybody does a 3-year residency now. When I graduated and did my residency in 79 and 80, it was a 1-year program. There were a few 2 years and a few 3 years, but now everybody's the 3rd year. When I started practice, I practiced for a year up north, and then I came down here. Most of this stuff, half the stuff that is done now was not done back then. I mean, it literally was not invented. We didn't have any internal fixation, and we didn't do ankles and legs. And now when the 2 programs that I work with, one at Northwest Medical and one at Bethesda, when they get done with 3 years, they're basically capable of doing any fracture in the leg and ankle. So it's amazing, it's 40 years now, but it's amazing the progress that we've made.
And those are you proctor students there at both Northwest and Bethesda?
I'm on staff at Northwest.
Oh, okay.
And Bethesda, I do surgery with at a surgical center in Park Creek, which is a little bit down the road. So most of the elective stuff I do at the outpatient surgical center, and the hospital stuff I do at Northwest Medical Center.
Oh, nice. And Northwest is in
Margate, right across the street from my office.
Okay,
so
and your office is in Margate.
Very convenient.
Nice.
I will step out of my office and boom, I'm right there.
And I have to ask you because I live in Boynton. So Bethesda East Side or the new one out west? Or?
They're both.
Okay, both. Oh, yeah, they're both
cover both.
Nice.
And now, like I said, both of them in 3 years. I think every podiatry residency now is 3 years. Nice. Which is at the Virginia, they've come a long way, baby.
Yeah.
Yes.
I think I'm counting in my head, that's 11 years total, the 4, and then, the 3. Wow,
yes.
that I didn't realize.
Yes, it's 4 years college, 4 years podiatry school, and then 3 years residency.
Experts. That's great for the South Florida community and beyond. One of the things we've talked about this, I don't even think this term a few years ago, it wasn't even something I even knew what it was, is wound care. And it seems to come to the forefront because now so much more information. People who are older in life, they ask that maybe you should see your podiatrist when you buy a new pair of shoes because the rubbing, or if you have diabetes, that's what I'm getting to.
That's the main thing, yes.
Yeah, because the rubbing, I had no idea about that until recently, but you're involved in a wound care case study. Tell us a little bit about that and how you got involved, and if you're looking for anyone to join the study.
It started probably in June. I have another doctor who works in my office, and I don't know exactly how she met this company, but they have 2 women that come out and put on what's called a total contact cast, which makes the patient non-weight bearing. And what it is, it's a diabetic who has a pressure ulcer on the bottom of the foot. And most of the time they have what's called diabetic peripheral neuropathy, which means they have a loss of sensation. If a quote-unquote normal human being had their problems, there wouldn't be enough pain medicine in the world. But half the times these people literally don't know that they have the problem until they see the staining of their sock. So what happens is we debride the ulcer, which is taking a scalpel blade and taking off the unhealthy tissue, and then we do all kinds of different paddings depending upon what happens once they're non-infected. And then they put the contact casts on, and it's a series of contact casts. They come back in 3 days the first time, then 3 days the second time, and once we know it's good, then they come back on a weekly basis until they get healed up. We've healed a few people within the past 2 months. But what it is people are able to walk on it because they put a walker on the bottom, so they're not immobilized. And you just have to be careful, and you have to know what you're doing, which is why these women do it, because if you do it wrong, problems can happen because diabetics don't realize there's a problem. And so it's been really good. I mean, we've helped people. It allows them to ambulate, and we've been getting people better faster.
That's great news as well. Now, is there any chance for anyone to get in that study if they come to see you, or is it
There's
closed?
no restrictions. It
nice.
Doesn't matter. There's no insurance involved. It's just these people are doing it as a research project, and I have no idea who funds them, but the patients come in, and I do the debridement, and then they do the casting. So you could have a HMO that I don't take, or you could have Medicare, or no insurance. It doesn't make a difference.
If you want to see what Dr. Perlmutter takes, the number is 954-974-0494. Like you said, located in Margate, 5800 Colonial Drive, Margate, Florida, right near, like you said, Northwest Medical
Directly
Center.
Across the street. And like I said, the nice thing about this is they couldn't care less what insurance you have because it's all done through whatever research company they're using. The other thing that they're also doing is venous ulcers. You know, people that have varicose veins, sometimes they break down. And they have a protocol for that also, which we just started. So they come in, once again, I do the debridement with a scalpel blade, and they use various products in addition to compression to try and speed up the process. Because getting rid of venous ulcers is very difficult. The key to that is compression.
Going back to diabetic neuropathy, did I get that right? The people aren't feeling that have that don't feel maybe the wound because of the pain sensors. It's just not.
Yeah, they're all different. There's symptomatic numbness, tingling, and pain, which there are medicines for, which we can discuss after this. And there's also people that have absolutely no sensation on their feet. I mean, they come into the office, and it's just amazing. I mean, intelligent people have no blessed idea until they see staining on their socks that they have a problem.
Wow.
And interesting enough, 50, maybe up to 75% of the non-trauma that I see in the hospital, because I rounded the hospital, is from diabetic ulcers. I mean, that's how big it is.
Wow, that's a lot. That's a high percentage.
They all come in, and some of them are infected, and it requires stuff. They get all kinds of problems. Well, we can discuss that also afterwards. But they had no idea. It's just the most amazing thing in the world.
Huh. And anyone who has been diagnosed with diabetes obviously should be seeing a podiatrist on a regular basis.
The most important thing I can tell them, I mean, some people don't have any symptoms. I mean, they're perfectly normal. They just have diabetes. But if you have neuropathy, especially if you have a loss of sensation, you need to look at your foot every day. I mean, if you have a significant other, they can look at the bottom of the foot. Otherwise, I tell patients to get a mirror and stick their foot up because they have no idea what the heck's going on.
That's a good point. And if friends, family, they can take a look for you. We always talk about friends, family, caregivers on this show as well. But yeah, the mirror as well. I mean, there's something all of us have.
And they go, God, why didn't I think of that? And it's it. And we also have, there are, a whole bunch of wound care people that specialize in diabetics. There's also, and most of the time I treat them myself, but something really bad, and we'll discuss the other thing also, is their wound care centers. Most of the major hospitals have wound care centers where they have a whole bunch of different specialists in one setting.
Yeah, because this has become very common.
Yeah, I would say 75, 80% of the stuff I deal with myself, once it gets really bad or they need different people, then I'll send them to some other podiatrists who will take care of that. And they have dermatologists, they have vascular surgeons, which is another problem with diabetics, which we might as well discuss now. A lot of them have really poor circulation, and which is half the problem. Is diabetic neuropathy and poor circulation. And with the new techniques now of endovascular surgery, which is not, how they used to open up the whole leg to do bypasses, they can literally go in through the groin and put almost like a roto-rooter down there. And it's an amazing what they can do. They do it one day, and 2 days later, the patient's out of the hospital.
Because it clears up the blockage of the blood flow, and the blood flows again.
Yeah, it's like in the heart, but it's in the leg. So they put all different kinds of, and there's a whole specialty. It's called interventional radiology that every hospital has, and we order the tests, and if it comes back that there's a blockage, we call the doctors in.
Now, podiatrists are a very important part of the process for vascular surgeons.
Yes.
Because of that.
Most of the time, we see them, and then we send them to the very few people go to a vascular surgeon from their circulation right off the bat. Nice.
Well, not nice, but I'm just saying,
yes.
The connection that you're always working with vascular surgeons, so you have, Rolodex of the top ones around, I imagine. Let's talk about a couple of different lower extremity, foot and ankle ailments. So what are, besides wound care you're doing a lot of, what are some of the most common ailments that walk into the office? Okay.
I have a fairly diverse practice, a lot of palliative, which is conservative care. I mean, a lot of older people just literally can't get down and cut their calluses and fungus toenails. So I do a whole bunch of that, which is basic podiatry. Everything from there runs from infected ingrown toenail. I mean, we treat all ages from kids up till 90, whatever years old. Most of the kids come in with either infected ingrown toenails or warts, all right? And depending upon the severity, we take care of it. You can sometimes do surgery if you have to. If it's really bad, we have to give them a shot and take out part of the nail. Otherwise, sometimes you can get lucky and just cut out part of the nail and get rid of the offending border. I used to do a lot of surgery on warts. The older I get, the less I do because it's disabling. I mean, if someone has what's called a mosaic wart, which is a lot of them, I'll send them out to a dermatologist because I just don't have a laser. I don't have enough of that to do. But 1 or 2 warts, I treat conservatively in the office, and there's no downtime. They come in on a weekly basis. We shave it down to bleeding, which is the only basic time you want bleeding, and then we have them put some acid on there. So it really, I mean, if you come in today, kids can play sports in 2 days. Nice. And most of the time, younger people get that. Usually over 25, it's very rare. People come in thinking they have warts, and it's usually a callus and a corn.
I had a plantar's wart once when I was a kid.
Yeah, it's the same. A plantar's wart is the same as any other wart. It's a virus. It's just on the bottom of the foot, which is called the plantar aspect, so it's called the plantar wart. But it's no difference.
I learned so much about that, like scientifically. I'm thinking about it now. Is the amount of tissues that it went down to, like you were saying?
It goes the whole level of the skin. It does not go through the skin, but it goes the whole level of the skin.
Yeah.
And like I said, it's one of the few times when you treat it conservatively, when you use a 15 scalpel blade, that you actually want it to bleed, because then you're down to what's called pinpoint bleeding, and that's when you know you hit the wart, not the healthy tissue.
Well, one more thing. So since we're on this, we got a lot of viewers on Facebook. If you have any questions, type them in for Dr. Jerry Perlmutter. He's 38 years in podiatry, at least 37 here in South Florida.
38 here and one up north.
39 total, 38 here, 5800 Colonial Drive, Margate, 954-974-0494. Takes care of kids all the way up to...
as long as they can get into the office.
Yeah, as long as they can get in there.
We treat a bunch of people in wheelchairs.
Yeah. So to talk about warts, one last thing on that sidebar. Kids play a lot in puddles this time of the year. I mean, we have a lot of rain. My mom, I think, said I was playing a lot of puddles at that time. Is that kind of...
Warts are a virus.
Okay, it's virus.
It has nothing to do with cleanliness. I jokingly say to the kids, did you kiss a frog? Because that's, one of the fairy tales. It's a virus. I had a wart on my arm over here that I got a long time ago freezed. I have no idea why I got it there. Yeah. And it's just a matter of susceptibility. It's like fungus. Some people get it, some people don't.
Yeah.
And there's nothing you can do to prevent it. It has nothing to do with hygiene, has nothing to do with the shoes, the socks, or anything else. It's just a matter of susceptibility.
Well, it's hard to believe we're already halfway through. Let's take a quick break, and on the other half, I want to ask you a little bit about orthotics as well. So we can talk a little bit about that on the You and Your Doctor show.
Okay.
Wow,
All County Healthcare has exciting news for any and all patients with COPD or other respiratory ailments. Listen to what renowned pulmonologist Dr. Keith Robinson has to say.
Hello, I'm Dr. Keith Robinson, board-certified pulmonologist, medical director at Fusion Health Pulmonary Rehabilitation, and a board member with the American Lung Association of South Florida. We have exciting news for patients with COPD. We now offer IPV therapy at home, which has been demonstrated to improve airway clearance, decrease hospitalization, and improve quality of life of patients with COPD. Please call All County Healthcare for more information about this FDA-approved therapy.
For further information, call All County Healthcare now at 954-717-7027. That is 954-717-7027. Or visit our website at allcountyhealthcare.com. You can also find us on Facebook, YouTube, Twitter, Instagram, and LinkedIn. Remember, All County Healthcare always puts the patient's needs first. Always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888-565-1470, and we will put you on the air to inform all our listeners. Now, back to our show.
Throw a few...
Hello, South Florida and beyond, and we're right back with Dr. Jerry Perlmutter, Margate, Florida. He's on staff at Northwest Medical Center, Bethesda's hospital group as well. Before we broke, I had an idea. I've been watching a lot of baseball, and I was shocked to see this. Plantar fasciitis is the ailment. A famous baseball player for the Washington Nationals, Ryan Zimmerman's already missed 53 games this year. I was watching last night from plantar fasciitis. We hear that term a lot common, but what is it?
Okay, the muscle on the bottom of the foot that everybody can feel is called the plantar fascia. Where it attaches into the heel, that's what's called an inflammation or plantar fasciitis. The spur, if you get an x-ray, is just an x-ray finding. It makes no difference whether you have no spur, a teeny spur, or an inch spur. When I started practicing, we used to grind down the spur, and I have no idea how many years ago they found that you didn't have to do that. If you cut the fascia, and there are all different ways of doing it, there's something called endoscopic plantar fasciotomy, which is they use a microscope. I've gone through 3 or 4 different procedures, and what I do now is slightly different. I do it all the way basically right under the big toe joint, where I cut the muscle and and the non-athlete we're talking about, it's 3 weeks. When someone comes in, because I see 100 to 200 heel spurs a year in plantar fascia, if it's painful enough, I give them a cortisone shot with local anesthetic. If it's not painful enough, I get them into either a over-the-counter arch support, which is inexpensive, or if they want, and the insurance company pays for it, it's a no-brainer. If they want to spend the extra money, I put them in a custom-made orthotic. 90-something% of the time, and we're talking about lay people, okay, you get them comfortable enough. I just had a friend of mine bring in his 13-year-old who is homebound, schoolbound, and she wants to make it in the tennis world. And I gave her one shot, made her a pair of orthotics, and he actually called me up today wanting to get a second pair because he didn't want to change it from her tennis sneakers. Most of the time, you can get people comfortable conservatively. The only other thing you can do, I mean, you can give anti-inflammatories, but that's not going to solve anything. The only time I do surgery is when a patient says, I don't want to live with this the rest of my life. And I said, okay, but you can understand, you're going to be 3 weeks non-weight bearing because you have to cut the muscle on the bottom of the foot. I'm surprised that they got to have the best doctors around that they can't get this guy comfortable. I mean, if he's been out 2 months, they could have done the surgery and he'd be back by now.
Yeah, it's hard to say without, having that case in front of you.
I have people that come in literally walking on the front part of their foot. That's how painful it can be.
It looks painful as well. You mentioned orthotics. We were getting into that a little bit. Explain to me what an orthotic is. I'm trying to think. It's like a piece that goes into the shoe.
You want me to take it off out of my shoe?
Sure. You got one on you?
As long as
there you go.
Hold your nose.
Wow.
Okay. You got to understand something. This is funky because I don't care what it looks like.
Yeah.
This is the shell. All right. I have a high arch foot, and it goes on the foot. This is a custom made one, and this is just probably the 4th time that I recovered it. But what it does in my problem, it distributes the weight. When people have flat feet and they pronate, which is the foot going to the inside, it builds up their arch temporarily. I mean, as soon as they take it off, it doesn't. Your foot goes back to the way it was. Most people, when they get plantar fasciitis, have something called post-static dyskinesia, which means it hurts like heck when you wake up in the morning. So what you do is you give them stretching exercises, and you tell them to literally bring the foot back as far as they can and massage the plantar fascia where it attaches into the heel. It doesn't help during the day, but that initial pain in the morning it helps with. The orthotic, most of the time, I would say 80% people have flat feet, which pronate, which goes to the inside. So it makes them walk more functionally. And that's what it is. The custom-made ones, we make a cast. There are all kinds of different ways to do it. I just happen to make a cast. I send it out to a lab. It takes 2 to 3 weeks, and it comes back. If people don't want to spend the money or they don't have the money, we give them the over-the-counter stuff, which is probably 75% effective. Most people get comfortable, and I would say 90% of the time, I use it for heel pain.
Oh, nice.
So it's injection if it's painful, orthotics, and if that doesn't work, and you can give, this is one of the few places you can give multiple injections. The worst thing that happens, and it sounds terrible, is that if you give too many shots, they pop the plantar fascia, and they're doing their own surgery. That's what I tell them. I said, and I've never had it happen to me because I don't give more than 2 or 3 shots.
Yeah.
If I can't get someone comfortable in 2 or 3 shots, 20 shots is not going to work.
Why am I thinking some orthotics maybe around the heel, they look like a plastic cup? Are they use those anymore?
I don't.
Okay.
Personally, I don't think it works. It's a little shock absorption, but it doesn't control the excessive pronation or the high arch foot where you're basically feeling in the arch. I mean, I don't get pain when I wake up in the morning, but without my orthotics, I can't stand for 20 minutes. And I play tennis, and I used to play basketball until my knee said no more. So I was playing 3 or 4 times a week with these things.
You're still playing tennis.
Tennis
regularly.
I played twice a week. I cut back because my knee said no more.
And we know that can be a very strenuous sport on the body, so that's good to know. Now, if anyone has, sometimes I notice like my shoes maybe wear a little funny, and this and that.
It's supposed to wear on the outside. It's never normal if you wear it out on the inside.
Oh, good to know.
I mean, it's called lateral or the 5th toe. It's never normal. You should never say never, but it's never normal to wear it on the outside.
So if we notice something, we can make an appointment with you, and that we could be considered if you see something for orthotics or whatnot.
I don't make orthotics for people that are asymptomatic, don't have any pain. Okay, and most of the time, like I said, it's for plantar fasciitis and heel spur.
Okay, good to know. It's Dr. Jerry Perlmutter, 954-974-0494, 5800 Colonial Drive in Margate. Where did you complete your education and training?
I did the 4 years at New York College of Podiatric Medicine up in Harlem.
Nice.
And then I did a 1 year, like I said, when I was in,
all
right, it was a long time ago. There were mostly 1 years, there were a few 2 years, and maybe 1 or 2 3 years. So I did a 1 year program at the Topeka VA.
At the Veterans
in
Affairs
Kansas, yes.
Medical Center.
I was actually the first resident, me and another co-resident, and I don't even think it's around anymore. The director left, and I don't think they just did it. But I did it 1 year. It was half clinic and half surgery. Now everybody does a 3-year program, and it's a combination of both. I mean, I round almost every day with the residents and try and impart. I mean, I don't do ankles. Okay, so that's for the better trained podiatrist. I mean, I know my limits, and I'm too old to try and save the world. I just say what I can save. So I know we don't have a few more minutes, but let me talk briefly about some surgeries, okay? Bunions, you either wear shoe wear change or you need surgeries. And there are all different kinds of surgery depending upon the deformity and how old. On an older person, I do a simple procedure just to get the bump off and straighten out the toe. On a younger person, you can actually literally break the bone, reposition it, put a screw in, which was not available when I was going to do my residency, and you can correct it. You can go further back on the foot, and if you have to, and actually fuse the joint between the big toe and the next joint back. And they're all, it depends upon the deformity. They're all done outpatient now. When I started, we used to keep people in the hospital for 3 or 4 days. That's how far we've come. A few other things real quickly, because I know we're running out of time. People have crooked toes or hammer toes. We can correct them as an outpatient. People have what's called an aroma, which is benign nerve tumor between the toes. Outpatient. Everything elective is outpatient. The only thing that's not done, you can even do an amputation outpatient now, as long as it's not infected. The only thing that's really inpatient now is trauma, where you have to fix metatarsal bones and ankle bones, because you have to put plates and screws in there. And even that, if you really push it, you can do that.
Nice.
It's just amazing what I get amazed when the third-year person graduates and they go, holy crap, I remember when they couldn't suture a foot.
Wow, that's great. Hard to believe we ran out of time. Let's have you back on in the future. Great talk.
I enjoy it immensely. Anytime you need me,
I do this a lot, and that was great. Dr. Jerry Perlmutter, 954-974-0494. Thank you. Have a good
Thank you for letting us share with you a longer and healthier lifestyle. If you have a doctor or are a doctor and wish to be on the show, call AMP2 TV.